And so now I will introduce our moderator for today, Dr. Mohammad Sediq Hazratzai. So Dr. Sediq is a trainer with the Lotus Project, and he's worked in research, healthcare, and humanitarian health programs for over a decade. He is a visiting professor at UC Davis, a credentialed principal investigator and program director with the Public Health Institute, and is also the director of the Sahat Initiative, which is a program that aims to improve the health and well-being of refugee and immigrant populations. And so without further ado, I'll pass the virtual mic over to Dr. Sediq.
Thank you so much, Helen, for the introduction and for going through the logistics. I'm honored to be the moderator for today's webinar. Thank you all for being here, taking the time out of your busy schedules to attend. Today, we are here gathered virtually to also commemorate World Refugee Day and discuss some of the pressing issues, including mental health and trauma-informed care. And it's also an opportunity for us to reflect on the courage and strength and the resilience of millions of refugees who are forced to flee their homes due to conflict, violence, and persecution. I had a chance to look at the list of people who have registered. Hundreds of you have registered for this webinar from coast to coast. Individuals from community-based organizations, resettlement agencies, care providers, and individuals from programs and policy. And your presence is a testament to the significance of this day and the issues we are about to discuss. As I mentioned, one of the issues that we're discussing today is trauma-informed treatment strategies, and that's why we wanted to have this webinar with a title From Crisis to Care, Trauma-Informed Treatment Strategies for Afghans and Other Refugees Alike. As you know, trauma-informed care and practices has become a kind of a buzzword, like social determinants of health and also adverse childhood experiences, or ACEs. We are so privileged to have with us today an exceptional panel of speakers. All are experts in their respective field and deeply involved with refugee issues. And in fact, two of the speakers, Dr. Reda and Dr. Koga, are refugees themselves. And there is so much richness and wisdom in their presentation and the insight they will share with us. I'm very humbled to be the moderator today. And with that being said, I would like to turn it over to our first speaker, Dr. Brandi Hawk, PhD, who is a supervising psychologist and assistant clinical professor in the Department of Pediatrics in the University of California, Davis Children's Hospital. And Dr. Hawk is also the co-creator of the parent-childhood care treatment model. Dr. Hawk, thank you for being with us today. So tell us, what is trauma and how does that impact children, especially the refugee children?
Thank you so much, Dr. Sediq, for having me, and thank you everyone for being here. I'm going to share my screen with you all. To start, I would like to say I would love to have an entire day to talk about what is trauma in children, but I have 15 minutes, so we're going to move fairly quickly through this. So the title of my talk for you is Trauma in Children, A Hero's Journey. And we're going to start a little bit differently than you might typically start a talk about trauma. So the first thing I would love you all to do in chat is to tell me, who do you think of when you hear the word hero? So write in the chat some of your heroes. I'm seeing lots of family members, resilient people, Malala, Prophet, healthcare workers. Excellent. So many people. Now, these people that you identify as heroes, how many of them had easy lives? None, zero. The people who turn out to be heroes in our personal lives and in the broader culture, whether we're talking about real people or fictional people, none of those people have easy lives. And so I wanted to set that up as we talk about trauma in children. So even though I'm a psychologist, I'm going to start with some information from literature research. And we think about most stories and nearly every fantasy story, there is something called the hero's journey. And so when you think about books that you've read, think about lives that you've seen, they typically follow this pattern. First, the protagonist, the main character, is living a fairly normal life. And then something terrible or wonderful happens that forces them to leave their normal life and go out in the world or make changes. And then throughout the course of the story, that protagonist confronts and overcomes obstacles. And then ultimately at the end, the protagonist is rewarded and starts a new life. So what I want you to notice is that in this hero's journey, trauma is central. And so while we talk about trauma as negative, and certainly we would prefer if no one ever had to experience trauma, there is certainly something about it that is central to our experiences and certainly central to the experiences of people who go on to become what we would call a hero. So what is trauma? When we talk about trauma, we talk about 3 E's. Trauma is an event that is experienced as distressing or overwhelming and has an effect on functioning. And that's a pretty broad definition and opens the stage for all sorts of different experiences to be considered traumatic. So we might have medical trauma, physical abuse, sexual abuse, death or separation from loved ones, exploitation, persecution, deportation, bullying, community violence, witnessing violence. All of these things are potentially traumatic and so many more. The important thing with trauma is that it's not just the event, but that it has been experienced as distressing or overwhelming, and it's affecting the person who experienced it. And we know that trauma affects people in many ways. First, it affects their body. So our bodies are beautifully made to deal with stressful, life-threatening, or scary events. And like all animals, we respond with automatic natural instincts to fight, fly, freeze, or appease. And these are not wrong. They are what our body does to respond to scary things in the world and to keep us safe. They are good things for our body to do. But the problem is that when we experience trauma, and especially when we experience chronic trauma, our bodies get stuck in these responses. So we should fight to save ourselves and protect ourselves, but the problem comes when we get stuck in fight mode. And so a tap on the shoulder might be interpreted as traumatic and cause us to fight. Or we get stuck in appease mode. And we have kids and adults who are people-pleasing, who say yes to everything, who don't stick up to them for themselves. And they're just trying to do whatever they can to avoid conflict. While that is very helpful in the moment sometimes, it can create a lot more stress long-term for a child. And we also know that trauma not only affects the body, but it also affects beliefs. It affects a child's view of themselves. Maybe things like, I'm a bad kid, I'm isolated, no one likes me, I am guilty, I am responsible for the things that have happened, I am unlovable, I cannot be loved. It affects views of others, that others might hurt me or others can't be trusted, that no one but me can keep me safe, or maybe even I have to hurt other people before they hurt me. And it impacts the children's view of the world. So the world might be considered a dangerous place. The world is unpredictable. I am alone in the world and I am deeply unsafe. And this combination of effects on the body and effects on beliefs ultimately result in effects on behaviors. Children who have experienced trauma are more likely to have behaviors that are difficult for parents and other adults to manage. They experience reactivity to trauma cues. When things remind them of their traumatic experiences, they get upset and overwhelmed and maybe tantrum or maybe become aggressive. They might reenact the things that they've seen or experienced. They might have flashbacks and dissociate, look like they're completely out of it, not participating in life or in conversations. They have an increased risk of tantrums and aggression. They are more likely to be hyperactive, to have trouble sitting still because their body is just constantly moving and preparing to deal with the next traumatic event. They might have a persistently angry mood and be irritable. And they might experience sexual behaviors, acting out sexually with other children or adults. And these behaviors are very hard for parents to manage. But not only do they have behaviors that are hard to manage, trauma also can impact behaviors that impact relationships. So these behaviors are really kids pushing other people away, including their caregivers who they need so much. So things like withdrawing, wanting to just be alone in their room, anhedonia, not having fun, feeling bored all the time, nothing sounding good, having a persistently negative mood, avoiding things, people, places that might remind them of their traumatic events, and therefore avoiding almost everything. Or the opposite, intense clinginess, needing to be with their parent at all times, following their parents into the bathroom, into the kitchen. Everywhere the parent goes, the child goes as well. Or saying mean things, saying things like, I don't love you, you're a terrible mom, I hate you. These things push people away when what kids need most is for those people to come close to them. And truthfully, trauma impacts almost every single area of child development. In addition to behaviors, which we just talked about, it impacts brain development. It impacts cognitions, the ability to problem solve and learn and concentrate. It impacts physical health, including sleep, eating, immune functioning, and ultimately leading to a shorter lifespan. It impacts emotional control. It impacts relationships. And it impacts mental health. And so childhood trauma is impacting all of these different areas of a child's life. It is harmful for a child to experience trauma. And yet there's so much that kids are experiencing. More than 50% of kids experience trauma. And when we're talking about refugee children, we actually are talking about more than just a single trauma incident. Dr. Michulka put together this idea of the triple trauma paradigm for refugee families. So not only are children experiencing trauma at one point in time, or even chronic trauma of one particular type, but they are experiencing 3 specific stages of complex trauma. So in their country of origin, they're seeing things like violence and death, experiencing war happening around them, persecution, loss and grief, and fear. And then once they leave that country of origin and they're in transition, there's additional trauma that comes with transition that's different than the original traumas. So trauma of fleeing home, fear of persecution and what might happen, fear of unknown dangers, the conditions in the camps that they're staying in, trauma during transportation, and lack of stability. And then ultimately, they're also experiencing trauma in their host country, acculturation stress, xenophobia, pressure for self-sufficiency, grief and loss, and a constant fear of deportation. So how can so much pain become a story of hope? How can trauma, so much trauma, become a hero's journey? Well, I want to just give you these words, multifinality and equifinality. We can think of it like a tree. Multifinality means that from one starting place, there are many different outcomes. Just because a child has experienced trauma does not mean that they are destined for one outcome. There's a million things that can impact that destiny and that path. And equifinality means that from many different starting points, we can get to the same outcome. So these are our roots of the tree. And so when we think about trauma, it's not one size fits all, but every child is their own tree, full of equifinality and multifinality. So what does this mean for our hero's journey? Well, the important piece here is not the trauma. The important piece is overcoming the trauma. This happens with help from friends and wise advisors, from learning new skills, and from family, cultural, and supernatural beliefs that provide strength and direction for children. So when we think about that, protective factors for our kids, they are the intervention. They are the way that children will overcome these obstacles. And this is just a grouping of potential protective factors, but there are so many more things that we can do as well. So in conclusion, all refugee children have experienced multiple complex traumas, and that trauma affects all aspects of life, but that does not have to be the ending of their story, because we know that all good heroes experience trauma. So when we're talking to children, whether they are our own children or children we work with, let's help them identify what their story is. Where is their hero's journey leading? And how is their trauma affecting their body, beliefs, and behaviors during this chapter? And what protective factors do they have and need, and we can support them with to make it through this chapter so they can get to that space where their journey is leading. Thank you very much.
Thank you so much, Dr. Hawk. I noted a lot, and there is so much else to learn in your slides and your presentations, from how trauma and hardship is part of our journey, how do we stack and trauma, and how does it affect our belief about ourselves and about others, triple trauma paradigm, and not being focusing not about the trauma itself, but how do we overcome it. Now I'm sure we will have time to get back to all of those, and I'm sure there are questions from participants as well. So at this time, I think we will let's shift to trauma and looking at trauma from a different lens, and build on the Dr. Hawk presentation. And as all of you know, different cultures have distinct ways of interpreting and understanding trauma. They have a different construct about illness versus wellness, and they express themselves in different ways, and understanding all these nuances are really crucial in treating trauma. So I have the honor of now inviting Dr. Koga to walk us through these nuances. Dr. Koga, the floor is yours.
Thank you, Dr. Sediq. Dr. Hawk talked beautifully about Joseph Campbell's The Hero with 1,000 Faces. I'm sure most of you know this model very well. And she placed the emphasis, she mentioned that trauma is central to the hero's journey. I would build on this and shifting basically the paradigm, and to say that the hero is central to the trauma journey, because identity is extremely important. Otherwise, it becomes a generic term. Whose trauma? What does it mean? It doesn't mean much in clinical sense unless we know exactly whose trauma are we talking about and whose journey are we talking about. But although we have now 30 years of cultural competence in the state of California, and legislated for accreditation and for licensing, a lot of providers do not conduct a formal cultural identity assessment. And worse, many providers still are using the term sensitivity instead of competence. Now, when you look at the continuum of cultural competence, you see from outright destructiveness, incapacity, blindness, and pre-competence, which is sensitivity, and then moving to competence and proficiency, and what our colleague Dr. Murray from UC Davis calls cultural humility. We see that in this continuum, sensitivity doesn't mean much. It doesn't mean sensitive, in other words, compassionate. It means to be somehow familiar with. I recall Dr. Satcher, the general surgeon, talking 30 years ago here in Sacramento. Would you like to be operated for your bypass, coronary bypass, by a sensitive cardiac surgeon or by one who's actually competent, right? So sensitivity means barely familiar, competent means competent. So in terms of competence, we have learned a lot about cultures and borrowed from cultural anthropology, various models, and acculturation from Barry and others. But we haven't zoomed in much on the identity, the cultural identity, and reducing the meaning of patient traumatic stories to a sort of combination of psychiatric symptoms within a cultural context creates basically misjudgments in diagnosis and treatment, stereotypes, and really borders on colonizing malpractice. Talk about colonizing refugee health and refugee knowledge. Moreover, PTSD, trauma, right, and other constructs have little value, explanatory value for Afghans, for example. They don't share the same Western assumption about how is trauma, what is trauma, how is it expressed, and how do you respond to that? So in EU, and I travel a lot in my work in EU, the brief cultural interview is part of standard assessment, the refugee center, but not so much here in the US. Unfortunately, I haven't seen it at the Sacramento Refugee Health Clinic in my time there as well either. So this questionnaire with 27 questions that are allowed for dialogue explores personal identity, ethnic identity, and social identity, which are not carved in stone, but fluid through the culturation, so creates various iterations. So this now in DSM-4 has included a cultural identity in the cultural formulation interview. So I trust that many of you are now familiar with the cultural identity. And at Davis, we, in our Ulysses program, we look at norms and values that constitute an image. An Afghan, for example, holds of himself or herself. What urges a person to decide what's right or wrong? What appropriate is normed as, as a behavior is normed as appropriate or not? Values that are negotiable, self-image with loss of self-efficacy, social status, social capital, support everything that happens with migration. So if we're busy in our fast-paced managed care, mental health system that's driven by coding, reimbursement, and American cultural self-reliance, we're missing actually the identity of the Afghan refugee patients, which is again, not static, but fluid, multiple, and ever-changing through acculturation in this new society. Now, when you look at the 4 decades old Barry's model, I'm sure you're familiar with this, and it's about the journey that a hero who comes to America goes through and has basically 4 quadrants, possibilities or pathways. Some are acculturating and become bicultural, and that's highly adaptive. Some are losing their own culture and become dissolved totally in America. These are assimilated. Some have lost everything and have gained nothing. This is the worst, marginalization. That's a negative identification with both cultures. And some are, like many in the African community or the Russian community, or the Mexican, they stay within their own ethnic community. That's separation. It's highly, healthy, but doesn't allow much for upward movement. So now, all these are important when you consider the triad of disease, illness, and sickness. To recap, disease is PTSD in the books. It does not exist in the clinic. The way it is experienced by the Afghan, Iraqi, Syrian, or Ukrainian patient is called illness, and it has many facets of the disease. And doctors are treating illnesses, not diseases. And then there is the profession that dictates what should be done, what's the patient role. All these are different between, the major difference between Western and Afghan expectations. As you can see in trauma, we have a repeat of the old Indian story, the 7 blind men coming across an elephant. Everyone is touching and saying, oh, this is a wall, this is a spear, this is a fan. So we have limited understanding, and our cultural and personal understanding or professional understanding, right? Psychiatrists, neuropsychologists, medical anthropologists, what have you, a resettlement agency, define and describes within their scope of view and their own understanding, which may be in conflict with the professional paradigm in psychiatry. But the Afghans have three explanatory models for mental disorder. It's either caused by biology, like schizophrenia, they do acknowledge that, or spiritual, caused by genes, like in Majnoon in Arabic, possessed by genes, or by mostly life experiences, horrible, adverse life experiences, war, displacement, family violence, and so forth. So it's important for us to, as professionals, to explore the Afghan refugee conceptualization and expression of distress, because there is a difference and dissonance in the way we cluster symptoms, present, and explain versus the Afghan patient. You may be familiar with Asabi, Naharat, Fishare Bala, Fishare Payin, Jigare Kun. These are idioms of distress used by Afghans to express discomfort, suffering, or extreme distress, like in the case of Jigar Kun. When you go through your, using your inventories and screenings, you may not have this unless you come across, Ken Miller and other Afghan works. So let me give you an example here. This is the case that we've seen of a 36-year-old woman, a Pashtun woman called Mahnur, who saw the killing of the eldest son the year before and said, my liver is bleeding, Jigaram Kun hast, and that fishar was high. So this doesn't mean much. It's almost delusional or aberrant to an untrained mental health professional. She was grief-stricken, anxious, as manifested in her naharat, and found herself thinking too much about the gruesome images of the son's body. So, of course, this lady knew that her liver was bleeding only metaphorically, not actually. But it pointed out to her grief, feeling very intense, very manifest physically, and her physical agitation. And yet she didn't get much help because she was deemed to have low mental health literacy. And she needed to be trained and oriented first to understand medicine and what is happening to her. But in our opinion, as researchers working with Afghans, we think that Mahnur was very literate in Afghan literacy, and the county provider was not literate. So why is only the refugee has to adapt to the system, why not the system does not accommodate the refugee? So she faced cultural barriers, structural barriers, like didn't utilize services because she understood that she is not understood. Her concerns were dismissed. And it's sad that we found her in the emergency room. So it is important that for the mental health service utilization by refugees, that the patients, if you target certain symptoms and without addressing other symptoms, to them may seem like an incomplete resolution. So that is why it's important in training to look and to understand their idioms of distress and to work with both, right? So maybe focus groups can help as well. Let me give you a concrete example of a work that we have done, my colleagues and I, and Dr. Ramos was chief of the Refugee Health Office for the state of California, CDPH, and Callie Patterson was a research scientist, and myself, we worked for 3 years on looking at trauma, depression, and anxiety, and we noticed interesting things in Afghan female patients. We compared the first and second generation of mothers and daughters, and we noticed that in the first generation, for example, in the way they expressed distress, they had words like "I am Jigar Ekun," and I'm thinking too much. I cannot hold emotions. I have Fishare Payin, migraines a lot. expressions like veins pulling neck and burn behind the neck, decreased appetite or increased wanted to scream, and to fight with the children, family, and poor memory was standard. At some point, I remember doing a mini-mental status examination, like for people who experience cognitive decline, because I suspected that, but was none. How somehow culturally, these older women were primed and programmed, educated to express distress through poor memory, right? Yet, younger generation, their daughters, did not have the Shigari Kun and Naharat. They had hopelessness and worthlessness. Self-esteem was plunging. But self-esteem is unknown to an old, Pashtun woman, doesn't know what self-esteem means. It's an American Western concept. So now we see that the younger generation has acquired an American identity in biculturalism and expresses the same problem, depression, with different words and different construction of meaning. So then you have a sadness, and somatic symptoms are similar, but not so much, migraines, and crying, social withdrawal, but no cognitive symptoms. They don't have complaints about memory. So when we look now at the stated cause of depression, why is this happening to you? Well, my mother is, ailing mother is left behind in Kabul or in Kandahar. My father needs a knee surgery. I don't have money for that. I feel guilty. I feel bad. I feel ashamed, right? So a lot of that, plus the humiliation in the States, living in poor neighborhood, drug, and crime-ridden. Why did I come here? What do I tell my family back home? I haven't succeeded. I don't speak. I don't drive. My kids are, driving me everywhere and translating like I'm a blind person. So we have to see the power reversal. And that's why the first generation is ill and suffering. About the second generation, I'm nowhere. I'm between my Afghan culture and the American culture, right? So we see a struggle now, like in those who are marginalized and belong to none. And we had a lot of work in the Bay Area with colleagues exactly on this. Another causes is financial difficulties, unemployment, worrying about parents, and not being to share emotions with their parents. That is a terrible intergenerational gap. So now to wrap up is we need to emphasize again that cultural sensitivity is insufficient and to some extent is offensive. Cultural competence is needed and cultural humility. And that translates into understanding clearly the identity of the person. The person, yes, is embedded in family, in context, in community, but the person is a person as well. The social identity, ethnic identity of the individual needs to be assessed, and skills are needed for that. Secondly, we expand the acculturation model. People don't move only unidimensionally in that Barry's model, but go back. Some bicultural individual revert to origin. They start renegotiating, say, I don't think I want to do this anymore. I don't believe in that. I'm returning. When you see a patient, is it the first generation? The 1.5, the bridge generation, the second? Which Afghan are you working? We cannot work with a generic Afghan. Such a thing does not exist, only in books, in bad books. And the context of reception is also important. Where is the assessment on that? How is the person received? How we do, is the cultural distress framed? Are they discriminated or not? Are they supported or not? So, sorry. Go back to this. So the enculturation is not a 2x2 matrix, but a very nuanced and fluid variation of patterns in choosing what to keep, what to adopt in your own country, what to reject, what to blend. You heard of the immigrant paradox, especially in the study done by Dr. Aguilar Gaxiola, a large study, the MAP study in America, Mexican-American mental health. Mexicans coming to this country first, they're more normal than irregular American citizen. And yet 10 years later, they become just as, local like us. So the problem is that, as they say in Spanish, la cultura cura, that acculturation is not always good for mental health. Staying with your culture provides sometimes more support that you are, programmed through evolution and cultural evolution for hundreds of years or thousands of years, and we have better mechanisms. But what happened now in this day and age in 21st century, when you have acculturation plus mixed marriages, plus changing of religion or interracial ethnic, what is the new Afghan going to be in 20 years from now or 30 years from now? Your own grandkids. So think of that complexity, how difficult would be basically to create an Afghan cultural, assessment, let alone validation of trauma assessment instruments. So automatically applying the PTSD label to victims of war, to Afghans that suffer violence, torture, displacement, is pathologizing them, stigmatizing, delegitimizing their own grievances. It could be counter-therapeutic, and the Afghan patient may get worse, not better. So it is important to build bridges between those clinical concerns and the social context in which suffering is embedded. So you do a cultural analysis basically to create that bridge. And important in working with traumatized refugees, the work is extremely taxing for the provider. So listening day in and day out, as I did at the refugee clinic in Sacramento, stories of atrocities and loss could lead to burnout in providers. So how are we to protect ourselves, providers, from that? So our next speaker, our respected colleague, Dr. Omar Reda, will talk about secondary or vicarious trauma and guide us in preventing and addressing it. Thank you.
Thank you so much, Dr. Koga. I learn so much every time I listen to your presentations, and I become excited. That's why I think I missed your full introduction when I was introducing you. Being so excited about your presentation. Apologies for that. Just to let everyone know that Dr. Koga is, in addition to being associate professor with UC Davis, he is the director of Ulysses Refugee Research Program at the Department of Public Health Sciences in the University of California School of Medicine. And Dr. Koga, in his past 30 years, his research work has centered on transcultural psychiatry. He was a former Dean of International Medicine in Cambridge, UK. And also he was an associate clinical professor of psychiatry at Tulane School of Medicine. And Dr. Koga is a member of World Psychiatric Association, Transcultural Psychiatry Section, the Athena Network, the UC Davis Global Migration Center, and a fellow of Royal Society for Public Health, London, UK. So now I would like to transition to our third speaker and panelist, Dr. Omar Reda. And Dr. Omar Reda is MD and board certified psychiatrist. He is trained in Harvard, and he is a trauma expert. And as I mentioned in the beginning, he's a refugee himself, and he is an author. I have read his book quite a few times, The Untangled and the Wounded Healer. And Dr. Reda, I would like to hear from you. And as you mentioned in your book, that all of us are in a way caregivers. When we are young, we take care of our elderly. When we are adults, we are taking care of our children. And as a teachers, firefighters, police, and community workers, all of us are in a way exposed to trauma of others while we are caregiving, right? So now tell us about the secondary and vicarious trauma.
Thank you, Dr. Sediq. It's an absolute pleasure to be with everyone. And really, hopefully we'll talk a little bit about transgenerational trauma. Yes, I mean, we pass our trauma story to our children if we don't really work through our trauma story. So I wanted to honor the refugee experience on this special day. And I thank everybody in the room for the beautiful work that you do. And, you know, for the record, I was never a refugee. I was an asylum seeker. My refugee application was rejected by the immigration judge in the United Kingdom because he claimed that he cannot see any evidence of torture on my body. And so many times we discriminate against our invisible wounds, the psychosocial impacts of trauma. And yes, we might talk about inter and transgenerational trauma. I also very interested in talking about the intra-generational trauma, which is what's happening in the here and now between the community members who maybe fought for and against a certain ideology. So I come from a country called Libya. Libya has been through a very bloody civil war in 2011. People died for and against Mr. Gaddafi. And the country is still really going through a difficult time until today. I see the same in Syria. I see it in other contexts. So that's why I'm a big fan of trying to break the cycle of transgenerational trauma through focusing on us and also on the relationship that we have with our loved ones. So I'm going to talk very briefly about, the reasons that we might develop transgenerational trauma. This is because some of our interpersonal spaces are unsafe. Many communities go through violence, slavery, colonization, oppression, genocide, and so on. And my experience, most of the trauma that I sustained was as an adult. So I didn't have much trauma as a child, but in the year 1999, I was forced to leave Libya. Unfortunately, even though I was working as an emergency room physician, was not involved in any political issues, my humanitarian activities were threatening, and I was unfortunately identified as somebody whose need is to be arrested and thrown in jail. Found myself just leaving the country, and that I never, wanted to leave. And that's one struggle for many of the refugees. We leave our home behind, but our home never leaves our hearts. So we continue to live with the memories of our home country, and also we worry about our loved ones, like Dr. Koga said. And in my case, most of my trauma was because of hate. So people hated who I am because maybe of my skin color or the way I practice my religion. Maybe I have an accent. And it's very interesting that when we hate someone, we're going to miss out on lots of their beauty. And that's why I'm grateful for the other speakers talking about the children and also about the elderly, some of the groups that are usually living on the shades and the shadows of the society. And they have been pushed into the margin, unfortunately, by multiple traumatic experiences like racism and hate. And in the case of refugees, it's not only PTSD. I agree with Dr. Koga. If we just pathologize people, we're not doing them any service. And I believe that, yes, maybe the trauma story did not start with you, but I believe it's our ethical and moral obligation that the trauma story should stop with us, so we don't pass our distorted trauma story to our children. And when it comes to hate, that's an experience that I faced many times. I came to the United States after September 11, only a few months after that. As a young Muslim Arab man, I faced lots of Islamophobia. And I believe people hate others for different reasons, like ignorance, like lack of exposure. And some people are actually repeating their own trauma story, repeating the cycle of violence, because maybe that's the best that they know in their family unit. And very interestingly, if you see the field of neurobiology, hate can actually create brain circuits inside of our mind, like subcortical structures and also cortical structures, like the frontal lobe, and that's affected by both love and hate. And very interestingly, in the research, you find out that love will cause more deactivation and disinhibition than hate. So for most hate crimes, they are premeditated, well calculated, while crimes committed out of love are usually ones that are quite impulsive, I would say. Hate cycles is also something that we can do something about. I invite everybody in the room in the field of psychology and also the field of technology to maybe collaborate and write a better narrative. Right now, we might expose each other to the other, what are the pictures of people who are different, who are our enemies, and we see that our enemies maybe are men with beards or women with hijab and so on. And so we really need to change that narrative, because when we put our children from different backgrounds together, they refuse to hate. They will play together and they don't care about each other background. We are not born to hate. Unfortunately, when people hate, especially children, it will affect many aspects of their life. So I have seen damaged self-esteem, children doubting their own beauty, losing their own voice, maybe taking out their trauma on people around them, and you know, even missing out. Many children of trauma, they grow up very quickly. So I remember like in March of 2019, when somebody walked into a mosque in New Zealand and opened fire, killing 51 people who were praying on Friday congregation. I remember the weekend after, you know, my neighbors were having barbecue because the weather was so gorgeous in the state of Oregon, where I used to live. I recently moved to the state of Colorado, and you know, I was sitting with a number of my community members talking about ways how we can protect our children when they walk into their Islamic schools or their places of worship. It's very important for me as a clinician, as a psychiatrist, to not only see my patients as symptoms. I want to focus on healing through justice and also healing through looking for beauty. I remember my professor, Dr. Richard Mulika, in the Harvard program in refugee trauma, he told me, Omar, if you don't look for beauty in every single encounter with your patients, then you are not practicing medicine. He told me to look somewhere else and practice another field if I don't pursue beauty and the search for beauty in every single patient, even if they don't look good or they don't smell good, because they are someone loved one. So when I meet my patient with that perspective, and I really are genuinely interested in their trauma story, many times many beautiful things will happen in the least places that you expect them. So I just came up with this, you know, advice for people who might be engaged as a predator or perpetrator of trauma, and people who might be watching or observing or witnessing a traumatic experience that's based on hate, and also the recipients of hate. So I ask you, if you are somebody who might have your own bias, to just stop. If you're gonna act in a hateful way, immediately stop what you are doing, literally, and take a deep breath, think of your options, and pick the option that you know, aligns with your best moral values. If you are bystander, many people die if we don't speak up on their behalf. So assess safety, connect with the victim, cause a distraction, and take an active stand. Make sure that you do that as safely as you can. We don't want to lose anybody because of a hateful incident. If you are the quote unquote victim or the survivor of hate, I ask you to raise your voice, speak up, involve other people around you, examine your options, and maybe you should exit with dignity. I'm a big fan of focusing on justice, and all of these slides are yours. If you can email me, I'll be happy to share all of my slides. So don't feel that you need to write any notes. But Dr. Mulika from the Harvard program, he showed us this picture. He said, this is a definition of an ideal city. And many of us, we were confused because there are no humans in the ideal city. And this is exactly the point of the artist who painted this picture. He said, every time humans walk into a beautiful place like this, they only cause destruction, corruption, and bloodshed. But I disagree with that. I think an ideal city is a place like this room where many clinicians are really caring about their clients and caring also about themselves. So that's why I created a model called Untitled. I'm going to talk very briefly about this before I conclude. But you know, to touch on the trauma story and humiliation, this is another way the Harvard program came up with this formulation. We need to focus on human rights, focus on the habitat, the health and self-care of people that we care about, and so on. So things that can help when you are working with the refugees who are facing hate, and especially those who feel that they don't have a platform to speak up, be their voice. Examine your own bias, get educated about the people that you're working with, refuse to hate, and also don't place the burden of fighting hate on the shoulders of the recipients. Speak up as safely as you can. Use your privilege to get people out of the shadows and margins of society. If we don't do that, many communities will continue to face poverty. They go into the correctional justice system. They might end up in the foster system, the state agencies. Many children might, unfortunately, get uneducated and lose employment and so on. And I am a big fan of, because many of you are caregivers, many of you are also wounded healers. So I want you to really take care of your own wounds, examine your family dynamics, pay attention to your loved ones, and break the cycle for you. The worst thing that you can do for your children is to pass your trauma story to them. So make sure that you don't pass a distorted trauma story to your children. And with that, I'm just going to very briefly, describe Untitled. This was created in 2011. Since then, it has become the Healing Trauma Institute. So Untitled is 5 components. I usually wanted to help any community that I work with through education, fighting stigma. A second thing is capacity building through training of trainers. The third thing is also building safe spaces, especially for honest, difficult conversations. The fourth component is building culturally humble resources. And the last one, maybe some communities might need clinical services, like an actual clinic, medication management, psychotherapy, and so on. So Rumi is somebody that I am a big fan of. He said, the wound is the place where the light enters you. So your trauma story might be the source of your inspiration and elevation. And you might discover many things about yourself because of a traumatic experience. And that doesn't mean that, our refugee brothers and sisters are always viewed as heroes. And some of them, they struggle, and it's okay to struggle. Doesn't mean that you are broken. Doesn't mean that you are less than a human. So I invite you to examine your roots, focus on your family, your faith, your moral values, but also focus on self-care. That's why created Untitled. So some of the activities under Untitled that we try to bond children with their parents through parenting seminars. You see, I had the pleasure of going to Bangladesh, working with the Rohingya refugees. Sometimes we do marriage seminars. So we bond spouses together so they don't have to engage in domestic violence. And unfortunately, some refugees that I work with, they live through what we call emotional affairs. And some of them, they live like roommates under the same roof, but they don't talk to one another, which is very sad to see. Many times, this is the love of what I do, is taking children to trauma-informed camps and retreats and nature, connecting them with each other, with the nature, with a high power of their choice. And also sometimes we use animals like traumatized horses, baby goats, and other animals. Sometimes we build clinics, like I said. And out of that, I was privileged to write a number of books about fighting hate, chapters about Islamophobia, anti-Semitism. And Untitled might look something like this. There is lots of trauma behind somebody who was walking the refugee experience, but there is also lots of hope. That's why I created Untitled. I wanted to break this cycle. And this is an animated film that's coming up very soon. It's actually available for pre-order. It's called Lamia's Poem. I was a psychosocial consultant for this book. It's how refugees might navigate their traumatic experience using art. In this case, it's The Book of Love by Rumi. So I invite you to take care of yourself because you are a wounded healer and you are the most important part of this team. So I think I'll stop here and invite any questions or reflections.
Thank you so much, Dr. Reda, for this very insightful presentation and excellent points and Thank you for sharing those books. And I have to mention that I have read them multiple times, and so much information, richness, and wisdom in there. I would like to begin with the quote that you shared from Rumi, that the wound is the place that the light shine in you. So in a way, trauma, obviously that negatively impacts our health and well-being, but there is often this narrative or misconception in the community that traumatized people are probably not good enough, or they have issues. That's even farther stigmatize seeking help and demonize the people who are already traumatized, right? So if you can tell us a little bit the positive side of the trauma, that's what happens. People become better human beings. So if you can shed a little bit more light on that, I'll appreciate it.
Yeah, thank you. And I agree with Dr. Hawk's definition, which comes from SAMHSA, the Substance Abuse and Mental Health Services Administration. They defined the trauma as three things. All of them start with the letter E. So it's not only the event or what happened to you, it's also the experience, the impact of what happened to you, on you, and everybody around you, and your own perception of your trauma story. So that's why I want every parent to work through their trauma story. Otherwise, they might repeat it. That's why if you go to the Healing Trauma Institute and look at the section where I shared my own trauma story, every time I get through a traumatic experience, I try my best to use it as a source of healing for others. So, for example, at age 11, I was about to be kidnapped for, unfortunately, sexual reasons. So that made me very keen on trying to protect children from sexual trauma. At age 6, I lost my sister for brain cancer. And she was 14, I was only 6. And she was the inspiration for me to become an emergency room physician. And then when I left Libya in 1999, went through the asylum seeking experience and then the Arab Spring, I found out I can be somebody who speaks on behalf of millions of refugees. It's my moral and ethical duty to do that. And then when I have seen the trauma story can destroy the family unit, I built Untangled, and we have built, me and my 3 daughters, YouTube channel. We call it the Daughter-Father Bonding Project. We have about 60 videos on YouTube how we can bond children with their parents, because many traumatized parents, they take their trauma story in the children, they shut down, they lash out, and we can break the cycle and find out lots of beauty if we really reframe our traumatic experience and we do it as a family.
Thank you so much, Dr. Reda, for sharing that personal experiences as well. Absolutely, that is what I often share with many students and my colleagues and people that I engage with, that sometimes trauma brings the best stuff in us, right? So a mom who loses her child to drunk driving, she advocates the rest of her life against drunk driving. As a parent who loses children to mass shooting, they continue to advocate the rest of their life against guns and mass shooting. And the story is almost everywhere. A cancer survivor advocate for cancer treatment and HIV. You can go on and on and on. Absolutely. Now I would like to ask Dr. Koga. Dr. Koga, if you tell us about this social aspect of the adversities, the trauma, and especially the Ulysses syndrome, right? There are clinical side of the health that are often rooted in social aspects of people, especially in the case of refugees and immigrants. So if you can talk a little bit about that for us.
Thank you, Dr. Sediq. We are talking about this for decades, and sometimes we feel, unfortunately, that we're talking to walls. Very difficult to change the status quo. when I mentioned sickness and the professional guild, psychology and psychiatry, the scope of work, norms, procedures, coding, and all that. So there's so much focus on PTSD, depression, anxiety that have become real entities. Our colleague, the former secretary of the World Psychiatric Association, Dr. Joseba Achotegui from Spain, University of Barcelona, has coined the Ulysses term almost 25 years ago. So what is Ulysses syndrome? Ulysses syndrome is the syndrome of the migrant with extreme stress. Ulysses is the Latin name for Odysseus. As you saw, and when you read, the Odyssey, Iliad and the Odyssey, or you saw the movie, the Odyssey, Odysseus, the hero of the Trojan War lives the war and tries to return home, but goes, instead of 40 days, it takes him 10 years. And to go through from trial to trial, tribulation, a lot of torment, and at the end arrives, and he's a transformed man, is hardened and wiser by the stress, just like a sword gets hammered and becomes sharper, and he is the evolutionary function of trauma as pushing evolution forward. So Dr. Joseba Achotegui talks that the refugee is not necessarily always and only a victim, is a hero as well, as Dr. Hawk opened actually the setting for today's webinar, is a hero who is journeying in a outside story and inner transformation. And we forget that the hero is not a person who has only PTSD, but is a person who lost their job. They practice medicine in Baghdad or in Basra or in Kabul, and now are driving Uber. They lost social capital. Their life is disrupted. Their father cannot be operated because there's no money here. So all these losses are coming from life. The mental disorder of the traumatized refugee comes not from the brain initially, comes from life and requires the life intervention. It's a social disorder, not mental disorder. By telling the Palestinian refugee, an occupied persecuted person that has a mental disorder, is to delegitimize their grievance. So it is important to understand that the Ulysses syndrome is like reframing the dignity of trauma, the dignity of the refugee, the dignity of the journey is extremely important. And we use that term, Ulysses syndrome. And we, Achotegui and ourselves and the colleagues and the institute, we develop scales and we work on that and validating and so forth. So we're open to discuss that more. But thank you for the question. It's extremely important because talking sometimes to the psychiatric or marriage and family therapy community, maybe we have not disseminated enough about Ulysses syndrome, like to normalize and depathologize human journey, especially of the migrants.
Thank you so much, Dr. Koga. The issues of refugees and immigrants, indeed, much of them are rooted in social issues, as you know, sometimes in our presentations, we talk about mental health, about trauma to a group of refugees, and at the end of the presentation, the questions we get are about legal issues, about employment, about integration, about housing, can't agree more. I will echo what you just said and really spot on comments. So now I would like to ask Dr. Brandi. Dr. Brandi, we have a lot of attendees from resettlement agencies, community-based organizations here on this call today. So what happens in a clinical setting? So let's say they see a family who needs support. How does the treatment looks like in a hospital setting? What components do treatments have? Especially you're extensively involved with PC care. So what should they take from this presentation today? The community-based organization employees.
Thank you. I would like to first echo what Dr. Koga just said, that a diagnosis of PTSD is not the be-all end-all. And I also know that we have a lot of people on the call today that need diagnoses in order to bill for services. And so it's this terrible catch-22 that we live in. And something that I have found, and I would love to hear Dr. Koga and Dr. Reda's perspective on this, is to talk to families about the medical system and how we do need to put a diagnosis in order to provide services, but that diagnosis does not define you. And that this is what we're actually working on, and working with the family to develop their understanding of what they've experienced and how treatment is going to move forward with that. And just clarifying that the diagnosis is purely focused on the need to bill. So just wanted to throw that out there. Thinking about treatment from a mental health standpoint, and I will focus on children rather than adults because I work with kids. I think one of the most important things, especially when we're talking about younger children, is to incorporate the caregivers. And so when you're identifying what type of treatment a child is getting, if it's effective treatment, you want to make sure that their parents and extended caregivers are involved to the extent possible. We know that children live in families, and so working just with a 5-year-old child and not including their parent in services is not effective. And so we need to see parents involved. And as was brought up, those parents need to have space to talk about their own experiences, to process what they have gone through and how that's showing up in their parenting and in their lives. We can't just focus on the child. We need to see the whole system. And so part of what we've done with parent-child care is create a brief intervention for parents and kids that allow us to teach positive communication, regulation skills, and behavior management skills in a short period of time and in the context of interacting and playing together. We are currently in the process of working with the International Rescue Committee to create a cultural adaptation of PC care specifically for forcibly displaced families. And so I'm very excited to be part of that journey, and we'll share more as it comes. But this comes out of the understanding that kids and relationships need to thrive. And so we need to help whole families when we're working with young children. And then if you're talking about older children, again, making sure that they're able to tell their story and they're able to process what happened to them, have someone who is culturally competent and able to help them explore things in a way that makes sense to them.
Yeah, thank you for sharing that, Dr. Hawk. Absolutely, child treatment should be considered in a family context, right? So, and not only narrowly focusing on children, but the families as well. And so, Dr. Reda, if you can tell us a little bit. I know I'm jumping from angle to angle. There are 3 angles for this issue. You are each one of you are touching on really a different aspect of the trauma. But before I move to the question to Dr. Reda, I would like to ask the participants, if you have any questions, please feel free to put it in the Q&A section. We have another roughly 10 more minutes, so our panelists will be happy to answer them. So Dr. Reda, if you could tell us, why do we become tangled in a past? Why trauma stick with us? And also, if you can, please touch a little bit on the vicarious trauma as well. As you mentioned in your book, the cost of caring, right? So I know there are 2 questions, if you can give us some information on that.
Yeah, so I agree with Dr. Hawk when you mentioned that, you know, in order to take care of a child or a family member, we need to empower all the systems around them. So I was in the refugee camps in Bangladesh, and, you know, the Bangladeshi community is extremely generous. At the same time, if you go to Bangladesh, it's an extremely poor country. And so when the United Nations was giving all of the humanitarian aid to the refugees, there was a little bit of resentment in the host community. So we told the UN a better approach is to also empower the local community. And this is what we do in order to help a child. We need to take care of the teachers and the parents and everybody around the children. That's why I'm a big fan of taking care of the caregiver. And many of the people in the room, you listen to horrific details of a trauma story, and you might get your own PTSD. This is what we call vicarious trauma or secondary trauma. And the more gentle and caring you are, this is the price that you pay for being compassionate. You might end up in compassion fatigue. And if you don't take care of yourself at that moment by knowing your needs and speaking up on your own behalf and asserting your boundaries, you might end up in burnout. And I know some people in the room might say, we know that, but we cannot afford, taking care of ourselves because it's a luxury. I would argue it's not a luxury, it's a responsibility to take care of yourself, because if you end up in burnout, everything that you're trying to prevent from happening is going to happen. All the people who are standing on your shoulders going to fall down when you fall down on your face. So make sure that in order to fill the emotional tank for your clients, that you have some gas left in your own tank, and make sure you don't only leave the leftovers for your family. I see many of the caregivers, they chase the American dream and they lose the American dream when they work many long hours and they take care of everybody else, but they come home to a very broken family dynamic. So I want you to not do that. If this is the case in your family right now, don't despair. There is always room for healing, but healing is intentional. You need to be aware of the issue and then be proactive. And I have noticed that children are quite forgiving of us as parents. As long as we follow every rupture in our relationship with the repair, they are willing to forgive us and re-establish connection. And there is nothing more beautiful than building a bridge between us and our loved ones.
Thank you so much, Dr. Reda. Dr. Koga, I noticed you were taking notes. Do you have any reflections or otherwise I had a question for you?
Yeah, I echoing what Dr. Reda said and started by Dr. Hawk. My reflection is basically on it takes a long time to shift the paradigm, as we see in the transition from DSM-3 to 4 and then to 5. I recall that's a generation. In psychiatry, if you live long enough and practice enough, you're going to see 2 DSMs. That's it, not 5 in a lifetime of practice. So I remember David Lukoff and Francis Liu, how they introduced the V codes in psychiatry, religious and spiritual experiences. And those now became the work of Harold Koenig from Duke and others have become the norm in psychiatry. So when we talk about moving from managed care view, narrow view, to wider psychosocial, complex, cultural, especially with refugees, it's happening. But it will take a long time, basically, for the managed care to code those things that Dr. Hawk and Dr. Reda are doing in their clinical practice, the soft aspect that's maybe not even paid for, to become part of standard practice. We have to be patient. These are moving slow like tectonic plates because it takes procedures, policy changes, and so forth. So although we have to keep hope, that is the point, and keep on doing what we're doing with the best heart.
Thank you. We have question in the comment section, and it says that when you speak out in your community or family, you become a black sheep. How do you deal with that? So I'm not sure who want to take that question.
I can speak up a little bit about my own experience working with people who found their own voice. And remember, like if you are somebody who your family members or your community is used to you being a doormat. The only thing that doormat does is for people to wipe their feet, and people will walk all over you because this is what they expect from you. So when you fight back and when you find your voice and you speak up and try to assert your boundaries, there will be lots of resistance in the beginning. But the more consistent you are with your own self-care, the more people will respect you. And don't do it alone. Find the right tone when you deliver your message. It's not only the content of the message, it's also the way we deliver it that might alienate our family members. At the same time, try to find allies. Don't feel that you are alone. So hopefully not the whole family view you as somebody who they need to be pointed out and singled out. At the same time, make sure that you consistently try to remind people that you cannot do it for them unless you also take care of you in the process. And I have found the people who consistently done that to eventually find their voice and people will respect them. Of course, it might not happen in every case. And maybe Dr. Hawk, you can, from your own experience with the children and teenagers speaking up and exerting their boundaries, there might be a pushback, and that's expected.
Yes, I was going to actually speak as a white person, right? That for myself personally, I became a Black sheep in my family when I started to talk about anti-racist work, and when people in my family learned about the work that I do. And that's really hard. But it takes doing a lot of work and understanding the white supremacy culture that we live in, understanding what we need to do for ourselves, because as people in power, we're the ones that need to make changes happen. We need to be able to lift other people up, and we need to not be silent. So it's, you know, it's hard, but I think it's a lot harder for the people who are being oppressed than for us to deal with being Black sheep in our families, which is hard, yeah. But to your point, Dr. Reda, working with kids, sometimes it's really giving scripts. I love to help kids find their comeback lines. What are you going to say when someone makes a racist remark to you? Or what are you going to say when your family comes back at you and says, like, you can't wear that clothing, or you shouldn't have these beliefs? How are you going to respond? And then having some really good comeback lines for different areas of life.
Thank you, Dr. Brandi. I had one other question for you, Dr. Brandi, about your advice to refugee families. And many of the attendees are, as I say, they're CBOs, resettlement agencies. They work with the refugee families and parents. I'm originally from Afghanistan, and I'm a father. And in the refugees who came last year and the year before, Afghans and Ukrainians, around half of them were children, right? So what do you suggest? What should we do? What should refugees do to take care of their children? And if you have some bullet points, advice, what they should do, what should they look for? Yeah.
Yeah, well, I created this magic pill that cures everything. I can't wait for everyone to have it. Unfortunately, it's not quite that simple. But I do have a resource from the National Child Traumatic Stress Network that I would love to share. I have to send it to everyone. I'm going to put it in the chat. I did not create this. I'm taking no credit for it. For some reason, it's not connecting. So here is the link. There you go. That talks about the very basic first steps for families, and it's creating routines and rhythms. So if we can create routines in our families, if we have a rhythm of a day, rhythm of a week, rhythm of a year, and maintaining rituals, particularly cultural and spiritual rituals that are important to families, it goes a long way in creating stability for kids.
Good. Thank you so much. appreciate sharing that. And for our attendees, just to let you know, this will be recorded and we can share this with you as well. Yeah, I think we have 1 more minute. Dr. Koga, you did mention about the idioms of distress and the construct that people have about expressing themselves, right? About trauma, mental illness, wellness. If you can tell us a little bit more about that, how Afghans express themselves, this traditional Western, let's say, anxiety, depression, PTSD, it doesn't fit in their language. Probably there is no terminology in their language. And if you can talk a little more about that and for our attendees.
Yes, thank you, Dr. Sediq. You can find resources, and we have a list of resources, and I recommend to take a look at Ken Miller's. Ken Miller used to teach at Pomona. He did a lot of work in Afghanistan. And we were honored to be part of the Afghan research teamwork with him some years ago. Ken Miller has something called the Afghan Stress Checklist, ACL. So look at that, and you're going to see in Pashto and Indari written questions that make sense to Afghan refugees, where the idioms of distress and the words like Naharat and Fishar, Fishar Payin, Fishar Bala, Jigar Kun are part of the questionnaire, where the way Afghan construct and understand and express distress, not mental illness, distress, life distress, personal distress. It is like my blood pressure is high and low, and that doesn't mean hypertension. Fishar is not blood pressure. Is my energy level is up and down, is low or high. Fishar, describes what a psychiatrist may call a hypomanic or manic episode versus a severe depressive episode. When Jigar could be an extreme, traumatic grief. And Naharat could be anxiety or GAD, traumatic anxieties. But these are approximations and do not correspond exactly to the Western constructs. So it is important, if you want to treat the Afghan, to diagnose the Afghan, to talk to the Afghan in their own language and their own construct. And if possible, then for coding, unfortunately, you have to use then the Western coding, or else the clinic is going to sink. It's not going to get paid, reimbursed. That is the problem that we talked about before, and that's going to change in time. Inshallah, is going to change, through a wider understanding of the system. But those are important. Maybe use those kind of instruments. Ken Miller's, instrument, Afghan Stress Checklist. It's very useful. Dr. Sediq and I, who's very modest, are also working on some cultural adapting ACEs, as with childhood experiences, and hopefully also PERS later on. Thank you.
Thank you so much. Really appreciate it. We have 3 more minutes, so if there is no other comments or reflection, I would like to pass it to my colleague, Ellen. It was really an enlightening discussion today with you. I would like to appreciate everyone time, questions, and participation. And although the webinar ends, but let's continue the conversation about this important topic. And I think together we can make a difference and create a more compassionate and inclusive world. Thank you all once again for being part of this important discussion. Stay safe, and for the logistics, I will turn it back to Ellen.